Everybody gets a good time. Beautiful. All right. Welcome, everybody. Welcome to October. It's fall. Halloween is coming. The holidays are coming. So welcome to the October version of the JVS Online Journal Club. I'm Misty Humphreys. This is Paul DeMuzio. We're going to be hosting or introducing the event. So I'm going to share my screen. And there we go. We have two great articles this evening. We have the long-term outcomes after lower extremity bypass in the actively smoking claudicant. I think this will stir up a little bit of conversation. And then, of course, we have the cryopreserved arterial allografts versus rifampin-soaked Dacron for the treatment of infected aortic and iliac grafts. I'm very excited to have Thomas Jefferson University and the University of Rochester as host institutions this evening. From the University of Rochester, we have Dr. Alaska Pendleton. She's an assistant professor of surgery. And then we have her second year vascular surgery resident. I'm just going to say Irina. I always get a little bit messed up whenever I say it, so to help with that. And then from Thomas Jefferson University, we have Dr. Babika Bai, Associate Professor of Surgery, Program Director for the Vascular Surgery Fellowship there. And then their fellow, Dr. Joshi. We have author guests that are with us tonight. Dr. Rohini Patel, who is a general surgery resident at the University of California, San Diego, and Dr. Malas, who is the senior author. And then Armin Tvei is a research trainee, and Randall DiMartino is also here from Mayo. So we're excited to have them answer questions. And of course, we have our two editorial board moderators that will be helping us. Gail Tang, Associate Professor of Surgery at the VA at the in Washington, and also Hao Pham, who is a Assistant Professor of Surgery at Virginia Tech. He's also a preceptor and lecturer at the Emory and Henry College of Health Sciences. Just a few small housekeeping things. Please stay muted. We'll ask you and prompt you to put your questions and comments in the chat so that the moderator can direct those to the authors. The event is being recorded for on-demand access. And then, of course, please join us for the November JVS Online Journal Club. We have several institutions that join as a group, just like MGH is doing. They're having pizza. It's my favorite food. I feel a little left out, but and our November episode, our November event will be on November 8th at 6 p.m. Central Time. The hosts for that event will be the University of Tennessee and Cedars-Sinai. So with that, I will stop sharing my screen and we'll kind of take it away.
Hey, I'm going to start off by introducing good. That's good. The subject of smoking in the lower extremity vascular disease. Thank you, Dr. Humphreys and Dr. DeMuzio, for inviting us to go over this topic and this exciting article. About 34 million Americans currently smoke, and this is one of the leading causes of preventable disease and death in the United States. Around 500,000 Americans die from smoking each year, and 16 million Americans are affected. It's very costly on the healthcare system. If you look more widely in the world, the prevalence of smoking is even higher than United States in many places. I'm not going to go too much into this slide, except to say that the SVS website has a really good toolkit for smoking cessation, and it talks about the effects of nicotine on peripheral arterial disease. When you look at the risk factors for peripheral arterial disease and the hazard ratios, there is 3 to 4-fold increase in hazard ratio for people who smoke and for people who have diabetes. These are the two risk factors with the strongest risk of developing PAD. Our group, a few years ago, looked at physician practices and habits of treating claudicants who smoke. This was a 14 questions survey sent to SVS membership. Interestingly, we found that more than 50% of the respondents would perform open surgery in actively smoking claudicants. We grouped them by region, and more interestingly, 60% or more of the physicians would offer endovascular surgery to actively smoking claudicants. In Asia and North America, there was a tendency for the physicians to try to get the patients to stop smoking before they did their procedure. We looked internally also at 287 patients. We presented this at Eastern Vascular a couple of years ago. This is our data. And when we looked at smoking and stenting, our patients, 36% were current smokers. And this is how the task classifications laid out. Interestingly, we didn't find any significance in the risk of reintervention between stenting and in smokers and non-smokers, and the time to stent occlusion. Even if when we stratified them with task classification, we didn't find any significant difference. Another study that looked at this was a meta-analysis that looked at open surgery, lower extremity bypass, and patients who smoked. This is a little older, from 2005, published in JVS. It looked at 29 eligible studies in the meta-analysis. Their data showed that continued smoking after lower limb bypass surgery resulted in at least a threefold increased risk of graft failure. They also showed that smoking cessation, even if it starts after the operation, restored graft patency towards never smokers. So it's never too late to stop smoking. Another study by Jones and colleagues, published in 2018 in JVS, looked at smokers undergoing lower extremity bypass and claudication. These were all claudicants, and they looked at primary patency at 2 years, assisted primary patency, and survival at 10 years. The study showed that smokers performed much worse compared to non-smokers in all three categories. This is a couple of their graphs from primary patency when they were unmatched and propensity matched. You can see that the non-smokers did significantly better. So smoking is bad. We should all aim for smoking cessation before lower extremity bypass, and even after the bypass, it's good to stop smoking. I'm going to stop sharing and invite Dr. Gaurang Joshi, our second-year fellow, to present the article. Thank you.
Hopefully everyone can hear me and see my slides. Good evening. Thank you to the JVS Journal Club for giving me the opportunity to present this interesting article titled Long-Term Outcomes for Lower Extremity Bypass in Actively Smoking Claudicants. Smoking is a major cause of death per year in the US, as Dr. Abay noted, and active smoking increases complications after surgical procedures. These include both vascular and non-vascular related procedures, and the complications are often related to poor wound healing, coagulation abnormalities, and cardiovascular and pulmonary events. So due to these complications, there's an ongoing precedent to suggest surgeon-delivered smoking cessation counseling before any procedure is performed. Smoking cessation is specifically important for patients with peripheral arterial disease because it's also a forefront in the non-operative management. It's been shown to decrease disease progression, improve graft patency, and overall lower the perioperative complications. And the SVS labels smoking cessation as a Class 1A recommendation. The aim of this study is to investigate the outcome of lower extremity bypass surgery in actively smoking claudicants and focus on the impact of smoking on long-term outcomes. Looking at the natural history of claudication, even when it's life-limiting, this disease does not usually require emergency life or limb-saving procedures. So the authors wanted to investigate if smoking cessation cannot only prevent disease progression, but also improve long-term outcome after bypass. This would also bolster the idea of whether smoking cessation should become a more prominent part of the vascular surgery office visit before and after a lower extremity bypass. The authors used the infrainguinal bypass dataset of the Vascular Implant Surveillance and Interventional Outcomes Network, the VISION database, and this is a collaboration between the VQI and Medicare claim data, which allowed for better long-term information. The authors then retrospectively reviewed all the patients in this dataset from 2003 to 2019 with an inclusion criteria that included any patient with arterial occlusive disease and claudication, and exclusion criteria were any concomitant suprainguinal procedure, aneurysmal pathology, acute limb ischemia, or any missing information. Smoking patients were classified into three groups: never smokers, former smokers who quit 1 month before surgery, and current smokers who continued smoking cigarettes, pipes, or cigars within the past month or greater than a month. Outcomes were assessed at 5 years, with primary outcomes being freedom from re-intervention, which was defined as any intervention after the index procedure, and amputation-free survival. The secondary outcomes were overall survival and limb salvage, defined as freedom from amputation above the ankle. Importantly, for statistics, propensity matching based on smoking status was utilized, and after appropriately matching the baseline covariates, the additional listed statistical analyses were performed. So this table looks at baseline characteristics of open lower extremity bypass in former smokers and current smokers, before and after propensity matching. Most importantly here, before matching, current smokers were younger and had a higher prevalence of COPD, and former smokers had more prevalence of hypertension, diabetes, coronary artery disease, and chronic kidney disease. After propensity matching, 1,451 pairs of former and current smokers were present. This table delineates the baseline characteristics of lower extremity bypass in never smokers and former smokers before and after matching. And the takeaway here is before propensity matching, former smokers were younger, more likely to have Medicare insurance, hypertension, coronary artery disease, COPD, or congestive heart failure. Going on to the results, this is the 5-year outcomes for overall survival, which is abbreviated as OS, freedom from re-intervention, FR, limb salvage, LS, and amputation-free survival, AFS. So before matching, looking at former smokers and current smokers, there was a statistically significant greater amputation-free survival, 67% versus 63% in former smokers compared to current smokers. After matching, former smokers also carried a significantly greater overall survival, which was 74% versus 65%, and amputation-free survival 71% versus 60.6% compared to current smokers. When comparing never smokers to former smokers, there was no significant difference in primary or secondary outcomes before and after matching. This table is showing the Cox regression for 5-year outcomes, comparing current smokers to former smokers before matching, there was a 13% increased risk of major amputation or death in current smokers. Once matching was performed, current smokers were found to have a 37% increased risk of all-cause mortality and 38% increased risk of major amputation or death. Again, when comparing former smokers and never smokers, there was no statistically significant difference before or after matching. These Kaplan-Meier curves graphically depict the worst amputation-free survival of current smokers compared to former smokers before and after match. And these Kaplan-Meier curves graphically depict no significant difference in amputation-free survival in former smokers and never smokers. The authors thus concluded that current smokers had a worse overall survival and amputation-free survival compared with individuals who quit smoking greater than 1 month before lower extremity bypass, and that quitting smoking can improve 5-year outcomes to match never smokers in terms of limb survival, limb salvage, reintervention, and amputation-free survival. The limitations the authors noted included the retrospective nature of the study, the availability of the data in the VQI Vision lower extremity bypass database, and since it's Medicare data, it's not generalizable to the younger patients. The underreporting of outcomes is also very prevalent in this database, and lack of smoking characterization, whether it's in the preoperative period or in the postoperative period, also played a role. Lastly, differences in practice patterns in postoperative anticoagulation and antiplatelets may also provide variable outcomes despite the propensity matching. Thank you.
Dr. Tang is going to start the discussion for this.
So there were a couple things about this paper that I thought were extremely interesting. One was the lack of difference between reintervention, really, between smokers and non-smokers or former smokers, because we usually say that, oh, your restenosis rate is higher if you continue to smoke, but that didn't seem to be the case. And do you have any thoughts as to why that might have been? So that's question number one. And question number two is, there's quite a high percentage of patients that got non-autologous or autogenous bypass grafts, which kind of implies that these were fem-AK-pop bypasses as opposed to below-knee bypasses, where I think people might shade a little bit more toward autogenous. Was there any way to differentiate that in the database information or from VQI to kind of tease that out a little bit better?
So for these, hey guys, this is Mahmoud Malas. I will let Rohini start answering these questions. I'm assuming these questions are to us, right? Or to the authors?
Yes, we usually have the authors answer.
Okay,
Yes.
so I'll let Rohini start first, take a stab at it.
Sure. Are you able to hear me? Okay, great. Thank you so much for allowing our work to be presented and presenting it so well. I really appreciate that. In terms of the questions, the VQI database is, inherently a little bit dirty. There's a lot of variables, but we don't quite have necessarily always the information that we're looking for from it. And so one of the things with smoking that I think is the biggest limitation with this particular project is that we really didn't have a great timeline for patients or any sort of sense of how much they were smoking at any given point in time. And so we really just had this kind of binary option of, were they a smoker, were they not, or were they a former smoker, which makes it really tough to know if a former smoker means someone with a 10-pack year history or a 50-pack year history, and how that can impact then decisions that surgeons are making in terms of product to put in them or the actual operation that was performed on them. And so, one of the things that we felt really strongly about with this project is that there's a lot of data that just compares smokers to non-smokers, but there isn't a lot out there that really looks at progression of smokers over time and if convincing them to stop smoking can change something and change their outcomes. And so that was really the crux of what we were trying to look at is if we can convince someone as a group to stop smoking, then do their outcomes change? So that was really, in terms of the actual, if it was autogenous or non-autogenous, we just have options in VQI that are picked by whoever is putting in the data of if that was done. So we don't know why necessarily those options were picked, which can limit things.
Okay, so there's a couple questions that are coming up in the chat. Well, three. One was, is there any utility in looking at the blood levels like cotinine or smoking byproducts in studies like this? Although obviously that's not going to be something that's collected in VQI. That's question number one. Number two is, you compare never smokers and former smokers, and then you compare former smokers and current smokers, but we never see the third comparison of never smokers to current smokers, or was it the idea was that because there wasn't any difference between the never smokers and the former smokers that the same differences would apply, and so there wasn't any point in doing the third comparison. And then on the last question was, when looking at databases, it's hard to get certain specific data. What were the available data and what was missing from the data set? Was the patency data available? And how do you determine reintervention? Because, from the vision data, can you actually get reintervention, or do you only get reintervention within 1 year? Because that might lead to my question, because, if you're missing the reintervention that happened on year 2, 3, 4, which might be more common in the smokers, then it's a little misleading.
Okay, so starting with the first one, blood levels like nicotine level or any sort of smoking byproduct. So I think that would be great if we could do that. And, we routinely, for patients that we're concerned about that haven't actually quit smoking, do that at our institution. But within VQI, we don't have that data available. So it's not something that we could really take into account on the VQI vision level. In terms of the comparison between never and current smokers, so we didn't look at that very closely because our goal, again, wasn't to compare patients who smoked to non-smokers. It was to compare patients who had ever smoked to non-smokers. So it was a very specific question that we were trying to answer. So that is something that we did not focus on at all, really. And then in terms of when looking at databases, missing data, patency, and reintervention. Yes. So reintervention with vision is actually tough. One of the limitations is that the laterality is not always indicated. And so it's really hard to then say, is someone's reintervention that's being coded in vision really due to the procedure, the index operation, or is it due to something else? So again, with big databases, there's a lot of limitations. We try to adjust for things as much as possible. We adjusted for the level of the bypass and really tried to take stuff into account that could kind of help clarify and represent that information.
So going back to the former smoker question, because you in your conclusions, you kind of say, well, as long as they quit within, more than 30 days in advance, they're going to have equivalent outcomes. But you have a lot of numbers, you have a huge number of patients who are former smokers, for instance. And so are you sure that you're not washing out the ones who quit within about 30 days after, with the bunch of people who quit like 12 years ago who have equivalent outcomes, right?
Right. And I don't know. None of us know with the data that we are provided with, but that is a good point. What is the time frame, the true time frame of when patients should stop smoking? Is it 30 days? Is it 1 year, 10 years? And I think that's just, it represents an opportunity for us moving forward as physicians, surgeons, vascular surgeons, like, is this something that we can figure out and then direct our patients a little bit better and then guide when we offer treatments?
Looks like Dr. Malas has a comment.
Yeah, so thank you again for choosing this article. I think it's super important. Sorry, I can't turn my camera on, but I think Rohini did a phenomenal job. And I think, Gail, you asked very important questions, and everybody, the presentation was very, very good. Covering, I think one of the questions you asked, I'm not sure if we answered that. It was about the level and having a lot of PTFE, obviously, but with all of that was adjusted for in the model. So the type of conduit and whether it's fempop, femtibule, or pot beetle, all of that was adjusted the best we could in the regression and the matching. So, the big picture, I think, within the limitation, obviously vision has a lot of limitation, VQI, everybody knows, but one couple of things that they're very difficult to fake or make mistake about. So vision, obviously Medicare, and as you guys know, nothing happened here without reimbursement and compensation. So it's pretty accurate. When someone get readmitted, no matter where they go in the country, they don't have to go back to the same hospital. They get admitted, and if they have Medicare, Medicare is going to pay for it. So it's very accurate as far as like the amputation. The problem, I think, the reintervention, the definition of the reintervention was very difficult. And the group VQI working on vision, they're trying to improve it, and it's constantly getting better and better. So Gail, you're right. I mean, I'm sure there's a lot more reintervention with smokers. We just couldn't really capture that within limitation of the study. But one thing we can't fake or hide is mortality and amputation, right? So amputation-free survival was obviously very well defined by the Society of Vascular Surgery reporting standards for PAD. And I think we all face this. We all see patients that are smoking and they're claudicating, and we try to get them to quit smoking. Unfortunately, there's out there in the community and everywhere else, and within our specialty, I'm not going to just point finger only toward, one particular specialty versus the other, that there's a lot of interventions happening. And, whether bypass or endovascular, of course, a lot more in smokers. And I think, if anything, that the big picture that this article kind of highlight is that, hey, you know what? If you get them to quit smoking, which is what the textbook teach you to do, you're going to improve their overall survival and amputation-free survival. And I think, it's pretty good message, loud and clear, And I also want to, finalize this, so I'm not talking too much, but I want, to highlight how amazing Rohini did, and she presented that at VAM and did an amazing job, and she is applying to vascular surgery. So you guys take notes. 5.2 fellowship. So good luck getting her, because we're going to do everything we can to keep her in UCSD. Okay. Thank you, guys.
There's one last technical question in the chat, and I'll ask you to respond to that in the chat, Dr. Malas, but I think we need to move to the next article.
Right. Thank you.
Thank you.
Of great discussion. I think this is kind of what we love about this, having the authors here to be able to answer these. Dr. Pendleton, do you want to go ahead and get started?
Okay, can you see this all right?
We can.
Awesome. So I'm Alaska Pendleton. I trained at MGH, and I am brand new faculty at the University of Rochester Medical Center. So I'll be introducing the topic, and then my excellent PGY2, Irina Kansafarova, will be leading us forward. Thank you, Dr. Humphreys and Dr. Demozio, for having us tonight. Let's see. So the incidence of prosthetic aortic graft infections ranges from 1 to 4%, and this is highly dependent upon patient factors and then also upon anatomic risk factors. So endovascular stent grafts, retroperitoneal grafts have less than 1% chance, whereas those that extend to the femoral level have a 2 to 4% chance. And it's important to differentiate between early versus late infections. So early infections are those that are occurring less than 4 months after implementation and are typically Staph aureus or gram-negative organisms such as Pseudomonas that are highly virulent and cause diffuse systemic manifestations and a suppurative reactions. This is where we get all those nasty pus photos. Your late types of infections occur greater than 4 months after implementation. This is your staph epi with indolent subtle manifestations and focal findings such as sinus tracts or draining wounds. There are a myriad of clinical manifestations, but I do just want to focus in on gastrointestinal bleeding. This is a common manifestation for aortoenteric fistulas, which I want to draw the attention to this because this does come up in the paper that we'll be discussing. And 65 to 75% of aortoenteric fistulas will be associated with gastrointestinal blood loss. So diagnosis, first you must determine the presence of the graft infection, which is not entirely straightforward given that despite all of these testing modalities, there's no perfect 100% sensitive and specific modality. And then the extent of graft involvement, which is important in determining your operative plan. So CT is our gold standard for diagnosis of aortic graft infections and can demonstrate perigraft fluid, perigraft soft tissue inflammation with loss of tissue planes, ectopic gas, pseudoaneurysms, and focal bowel wall thickening, which is more indicative of a fistula. So let's think about our reconstructive options. So total graft excision with ligation of the aortic stump and extra anatomic bypass is appealing because all prosthetic graft is removed. This most frequently involves unilateral or bilateral bypasses from the axillary artery to the profunda, the femoral artery, or the popliteal arteries. In stable patients, the two components of this approach may be staged. A disadvantage of aortic ligation with extra anatomic bypass is the 2 to 5% risk of stump blowout. And considering patency, a study by Seeger et al. Found that the 5-year primary patency for the AXFEMs was approximately 64%, but none of the axillofemoral bypasses in a series were patent beyond 7 months. In addition, cross-contamination and reinfection of the new prosthetic graft occurs in 10 to 20% of cases. So typically we're reserving this option for patients who are too ill or unstable to undergo a more definitive procedure. And so that's not the patient population that we're dealing with in this paper. So let's move on to in situ repair. Various conduits have been employed for in situ repair, including autogenous femoral popliteal vein or NACE, human allografts, and then prosthetic grafting. So considering prosthetic materials, early attempts at this strategy were hindered by rapid attenuation of antibiotic concentrations. However, coating of grafts with either collagen or gelatin allows the chemical bond to form between the graft and the antibiotic. We most commonly use rifampin for a couple of reasons. One is that it has high sensitivity for the staph species that most commonly are infecting our grafts. It does not redistribute rapidly into the bloodstream because it's hydrophobic in nature. And then finally, we just don't use it that much. And so the risk of resistance is fairly low. A third option is for in situ replacement is the use of aortic segments that have been harvested from transplant donors and rendered non-antigenic by cryopreservation. Aortic allografts were first used as a conduit for arterial reconstruction as early as the 1950s, but issues with this approach, which we'll talk about in this paper, include allograft dilatation, aneurysm formation, kinking, stenosis, and occlusion. And then finally, NACE offers a large caliber autogenous conduit that is resistant to reinfection and offers excellent long-term patency and obviates the need for long-term antibiotics post-operatively. In 187 patients, the 30-day mortality was 10%, procedure-related mortality was 14%. Considering complications of this procedure, 15% of the patients had ipsilateral venous insufficiency, but the majority were C classification C3. And there's also concern regarding the technical demands and length of this procedure, particularly in our sicker patients. The average case time for this is about 9.3 hours, and average EBL is 2.6 liters. And then finally, considering anatomic factors, your femoral vein must be at least 5 millimeters in diameter to be used for your aortic reconstruction. So that brings us to the question, in a patient who is a candidate for in situ repair, what is my best option for reconstruction? And with that, I will hand it over to the incredible Ken Safarova.
All right.
You want to quit sharing your
Still
screen?
unshare screen. Yeah, thank you. All right. First of all, thank you to JVS Journal Club organizers for the opportunity to present a very interesting article today. As Dr. Pendleton said, there's still no consensus on the best in situ reconstruction options for patients with iliac or aortic graft infection. That's why a research group from Mayo Clinic conducted a study to compare the rates of graft-related reintervention, reinfection, overall survival, and perioperative morbidity in patients with infected aortic and iliac grafts undergoing in-situ reconstruction with either cryopreserved arterial allografts, CAA, or rifampin-soaked Dacron grafts, RSD. This was a retrospective single-center cohort study, which included adult patients with infected iliac, thoracoabdominal, or abdominal grafts who underwent cryopreserved arterial allograft or rifampin-soaked Dacron graft reconstruction. Patients with primary aortic or iliac infection, or patients who underwent extra anatomic bypass reconstruction or reconstruction with autologous vein were excluded from the study. Graft infection was diagnosed by typical imaging evidence, intraoperative findings of frank pus, intra-abdominal abscesses or fistulate connections to the uterus of bowel, and by intraoperative cultures and pathology results. Primary outcomes included freedom from reinfection and from graft-related reintervention. Secondary outcomes were trends in the use of cryopreserved arterial allografts or rifampin-soaked Dacron grafts at the institution, overall survival, and perioperative morbidity. Data was collected on patients until the most recent follow-up or clinical encounter. So 49 patients were included in the study. 80 patients were included in the rifampin-soaked Dacron group and 69 patients in the cryopreserved arterial allograft group. There were no significant difference in age or medical comorbidities between groups. However, more male patients were included in the cryopreserved arterial group. Associated infections were diagnosed either during preoperative imaging evaluation or intraoperatively by visualization of abscesses. Iliac muscle abscesses were diagnosed in 30% of patients in the cryopreserved arterial group reconstruction, compared to 10% of patients in the rifampin-soaked Dacron group reconstruction. Index open repair was performed in 76% of patients in rifampin-soaked Dacron group, compared with 40% in the cryopreserved allograft group. This slide depicts patients' presentation and preoperative characteristics. The most common symptoms in both groups were fevers and abdominal or back pain. 82% of patients in cryopreserved arterial group reconstruction received preoperative antibiotics, compared with 63% of patients in the rifampin-soaked Dacron group. Patients in the rifampin-soaked Dacron groups were more frequently diagnosed with graft enteric fistula, and they had more urgent procedures. Interesting to know how use of cryopreserved arterial grafts and rifampin-soaked Dacron grafts has varied over the study period at the institution. In the early study period, the majority of patients underwent reconstruction with rifampin-soaked Dacron grafts. Then, in 2018 and 2019, only cryopreserved arterial allografts were used. More recent years showed use of both conduits. Complete resection of the infected grafts was performed in 85% of cryopreserved arterial allograft group patients, in comparison with 57% in the rifampin-soaked Dacron group patients. More patients in the cryopreserved arterial allograft group required aortic iliac graft reconstruction and higher level of proximal aortic clamping. Resected grafts were routinely cultured to guide further antibiotic therapy. More patients in cryopreserved allograft group showed unimicrobial growth. This slide depicts post-operative data and complication rates. And as we see, there were no significant difference in early mortality or complication rates between groups. More patients in the rifampin-soaked Dacron group were prescribed lifelong antibiotic therapy. Median clinical follow-up was 21.5 months for rifampin-soaked Dacron group patients and 20.5 months for cryopreserved arterial allograft group patients. There were no significant difference between groups in the overall survival at 1, 3, and 5 years after intervention. Intervention rate during a 4-year follow-up period was 3.8% in the rifampin-soaked Dacron group and 17.4% in the cryopreserved allograft group. There were no significant difference in the reinfection rates between cryopreserved allograft and rifampin-soaked Dacron group long-term. However, 13.6% of patients who underwent partial graft excision were diagnosed with reinfection, compared with only 3.8% of patients who underwent total graft excision. And considering the rifampin-soaked Dacron group only, 6.5% of patients who were discharged on lifelong antibiotic therapy were diagnosed with reinfection during the follow-up period, compared to 28.6% of patients who did not receive a lifelong antibiotic therapy. So, this paper showed that both cryopreserved arterial allograft and rifampin-soaked Dacron graft reconstruction showed to be viable options for in situ reconstruction in patients with infected aortic or iliac grafts with comparable early and long-term morbidity and mortality outcomes. Reintervention was necessary in a high proportion of patients in the cryopreserved allograft group, where there was a trend towards a higher reinfection rates in the rifampin-soaked Dacron group. Thank you for your attention.
Dr. Pham, do you want to start with the questions?
Yes, thank you for the great presentation from the Rochester group. There is one question on the chat for the authors of the paper. The question is, could you discuss the difference in cost of Dacron grafts as compared to cryopreserved grafts? If the clinical results are inferior, as by the study, and the cost is higher for the cryopreserved grafts, what is the place for the cryopreserved grafts?
I'll let Armin respond. I put in a partial response there, but I didn't mean to jump the gun. Armin's a medical student who worked with us from Sweden. I'll let him also discuss this. This was his project start to finish. So great work, Armin.
Thank you, Dr. Martino, and thank you to the JVS for the opportunity to discuss our paper. The reason to use cryopreserved grafts is something we've discussed at VAM and with our group at Mayo and with Dr. Martino as well. And we, as Dr. Martino wrote, we don't believe that the cryopreserved grafts are inferior per se, but we have shifted our use towards the cryopreserved grafts and use them in a specific group of patients. For example, those that have gram-negative infections such as Pseudomonas or MRSA as the potential cause of the graft infection. Also, if patients have a intra-abdominal abscess or frank pus as a cause or noted incidentally during the operation, we tend to prefer cryopreserved grafts. Rifampin-soaked Dacron grafts are more often used, as shown in the paper, in urgent cases, and this is because of the not needing to be thawed and that it is readily available. So we've basically used it in a different group now. However, this project also spans 20 years, so our group or our standard practice at our institution has changed during this time.
Yeah, I'll sort of add, when I've been at Mayo Clinic for about 10 years, and there was a big swing in enthusiasm for cryo, and most trends sort of go in different directions over time. I think, as you get experience with things, I think we had overcome the initial historical issues with cryopreserved grafts of blowouts. That's actually a very rare issue we've seen. And there was some more enthusiasm for the use of these, mostly to prevent reinfection and get off antibiotics, which often is a troublesome issue for patients, the ability to be suppression antibiotic free. And they were used in a lot of reconstructions involving the paravisceral aorta too, for infection. So having to debranch renals and mesenteric vessels, which requires a lot more prosthetic if you're going to do that all with Dacron. That said, as you see issues come up, you want to look at your data, and that was sort of the purpose of this project, was really to help inform the decisions. I have no conflicts with CryoLife whatsoever, and I don't think they like me because I put out that there could be more reinterventions for these things. But I think that we've shifted maybe to very focal things like graft enteric erosions, being very probably suitable for rifampin-soaked Dacron with an omental wrap. Cryo is something I would use for everybody who has a graft infection, but certainly I think there are patients like highly contaminated fields where it offers some value of trying to resist reinfection in this clinical scenario. So I don't expect this to resolve a debate about the most ideal conduit for these complex cases, and I think case by case, but I think if you're going to use one or the other, you sort of need to understand what the pitfalls are. And I think that's what hopefully our data is able to give people, so they can, take the best care of patients that they have in front of them.
Thank you for that response. We have another question from the chat group. It looks like the index surgery of open repair occurred in 61% of patients in the rifampin group and 28% of patients in the cryopreserved group. Does this mean EVARs or endovascular repair as an index operation were included? And did you do any secondary analysis to restrict the open only or compare the two?
Yes, thank you for the question. We did include endovascular stent graft infections as well, and in the cryopreserved group, a higher percentage of the infections were stent graft infections, and we did also perform the Cox proportional hazard regression, and we did not see any differences in any of the outcomes, depending on what type of graft infection it was.
Thank you for that response. Another question from the audience. Your overall survival was quite high compared to the previously published series. Can you talk about your management strategies and selection of criteria for operation versus suppressive therapy?
Maybe I can jump in for that one. Armin doesn't see all the ones we didn't operate on, which actually honestly, they're not that many. We don't have a aggressive approach for antibiotic suppression for grafts in general. I think patients who we think have any fitness for surgery are offered the option for surgery. That's not to say our results are perfect. They're far from it, but as a strategy, we don't sort of use that as a first line because typically the long-term response is not great from suppression alone. So I think it has to do a lot with perioperative care and operative approach to try to take care of the patient as best we can. So multidisciplinary care of the patient, dedicated vascular teams, dedicated vascular ICU care, and floor care, so start to finish. They have groups that are familiar with the patients. We're sort of averaging graft infections coming through. I think based on this, it's every month there's somebody coming through with something of some type, with something infected. So it's a regular thing for folks to see and try to manage. And we have we're fortunate we have cardiac anesthesia who staffs our room. So they're really great at resuscitation and the understanding the cardiac physiology needed to be managed during the operation. So I think that all goes into it.
Thank you for that response. Another question from the audience. Do you think the fact that the much worse bacteria in the cryograft biased the result in favor of the rifampin-soaked cohorts?
Thank you for the question. It is possible, and also we did see a higher percentage of intra-abdominal abscesses and iliac abscesses in the cryopreserved group. However, we didn't see any difference when adjusting for Cox proportional hazard regression analysis. But But when we tried to do it for bacteriology, we couldn't do it because of the low sample size in each group. So, but it is definitely possible, yes.
Thank you for that response. Another question from the audience. Can you comment on the patients that had negative intraoperative cultures? Did they clear the infection prior to the OR?
I guess if I understand the question correctly about culture negative grafts and I mean our strategy is typically not, patients who need emergent surgery go emergently to the operating room, but patients who can be, I've actually managed patients with graft infections for several weeks to either drain local abscesses and try to quell the infection and simmer it down best we can before going to the operating room. So that has some impact. Some probably anywhere between 20 to 40% of patients are going to have a culture negative graft, unfortunately, and that probably has to do some with antibiotics and getting them on board before you get a definitive organism. So I think our results are somewhat in line with historical trends in graft culture negative scenarios, which are always frustrating because then it's tough to know what to target them for suppression afterwards.
Thank you for that response. Another question from the audience. Is the risk of re-intervention related to increased anatomic complexity in patients treated with a cryopreserved graft? These patients were more likely to represent redo laparotomy and were more likely to require entire graft explant, more likely to have psoas abscess, and more likely to require bifurcated graft rather than to two grafts. So did the re-intervention, was it related to the increased complexity of those factors?
We did have in the cryopreserved graft more patients that had graft stenosis and occlusion, and half of those patients were of the deep branching grafts. So if it required a deep branching to the SMA or to one of the renals, that graft stenosed, requiring an endovascular intervention compared to our rifampin-soaked Dacron group. So that is also definitely possible.
And those are all the questions from the audience. A question from my standpoint: how does your group at Mayo Clinic, where does the extra anatomic bypass fit in your paradigm of how to treat these patients?
I think it's part of the armamentarium, but I'd say it's rarely used as a definitive therapy, because if you have to go in to excise the graft, that's the redo laparotomy, and even taking out an infected graft you're not going to reconstruct is still a big deal. It's not easy to get back there and get it all out and then oversew the aorta. So we've sort of fallen out of favor in doing that in most scenarios. And if you're going to explant it, you've done half the work of the reconstruction already. And so putting something in place seems a lot reasonable. I think if we had somebody we have had patients who had such complex infections that reconstruction just as an anatomic really we thought was their only option, but those are very few. I don't know if Armin probably came across all of them in general, but it's pretty rare that we will do that. Similarly, we didn't have a lot of deep vein NACE procedure grafts to sort of include, which is why we excluded them. They were a small group in terms of our approach, and that's had to do with the extent of the operation and sort of the manpower needed in trying to get folks through one operation more efficiently.
I just wanted to add, we had 12 patients in the past 20 years who had a NACE procedure and 7 who had extraanatomical. So small group.
And this question is from the audience. Do you routinely use ureteral stents? And because the inflammation in these patients, as you know, can be a problem.
Routinely, yeah. The data doesn't suggest that it's going to prevent injury, but more likely to prevent recognition of injury. But routinely, if there's anything with redo nature, we'll have urology come in and place externalized stents that are removed at the end of the procedure or within the first 24 hours.
And one question from me: when you have patients with iliopsoas abscess or enteric communications, does that when you were you able to exclude that from your patient group to see if there was a difference between rifampin and the cryopreserved group? Because we've seen paper actually published in the by the low frequency disease group that does show that communication with the bowel does have worse outcome. So does that when you exclude those patients, did that give you a different outcome?
Yeah, it didn't for our paper. I know that paper had a larger sample size, so I believe it might have something to do with that, but we didn't see any differences when excluding the aortoenteric fistulas.
Well, thank you. Those are all the questions from the audience and questions from myself.
Misty had to take off to the OR, but I want to congratulate the authors on fantastic papers. Great work, super job advancing our knowledge in these areas. And thank you for the presenters, wonderful job, and the mentoring of the trainees, as well as to our discussants and to the audience. Everybody have a great evening, and thank you for joining us. And we will catch you next month if you can. All right, take care.
Yeah, Alaska.